Okay, so now we're doing the treatment box. Where we get the Peter, let's go to the treatment box here. Alright, so this is a treatment box in the module for all these different syndromes that we've been talking about. Some of this you know, some of this you don't know, probably. Carpal tunnel, we check for the failings, as we know. You can, with the failings, be careful not to hike your shoulders too high. You can provoke cubital tunnel. If they can't flex the wrists, okay, so if you can do reverse failings. You may have heard about doing the reverse failings. What I mean by that, that's like a prayer kind of thing, putting your hands together. But it's not as sensitive as the failings. And as you realize as you're doing the reverse failings and the failings itself, you're flexing your elbows. So you get a false positive. Could be the ulnar nerve that you're pinching, not the median nerve. So a good way to do the failings, it's not so much your hands together, but as your hands out to the side and just flexing them, that'll probably do it. Don't hike your shoulders when you do it as well. But again, as we get through these tests, just at this point in the class, try to get away from obsessing over how to do a test, exactly like it's in the video or whatever, and think, what am I really checking out anatomy-wise? What am I trying to see? I'm just trying to compress that carpal tunnel. The failings will compress it, but I don't want to compress other things, and the reverse failings will compress it as long as if I can't do it. So kind of look at the whole picture, try it, think about the anatomy. Definitely do your Tinels, some good tapping with that median nerve path. That'll tell you a lot. So the failings in the Tinels are how you test and kind of tease out, is it carpal tunnel or not. You can't really diagnose it for sure without an EMG, to be honest. How do you treat it? Ergonomic assessment, that 90-90 thing, keeping your wrist is in neutral, avoiding the repetitive motions, obviously, especially with the flexed wrist. Splinting into neutral, a little bit of extension. There's kind of some discrepancy there here in the literature, but totally flat to just a little bit of extension, 10 to 15 degrees. Usually at nighttime is when you want to start. You get the best results. Splinting does work. There's good evidence for it. Exercises, the median nerve glides. Be careful with these. They can provoke it. Makes sense though with the glides because it is a median nerve thing. Get them moving. Flow's a big thing. Lumbrical stretches. There's some down there below the treatment box. I'll go through those in a second. When you're doing your modalities, think about calming it down. Ice, pulse, iontophoresis, steroid injections are common. And then you'll see some people potentially carpal tunnel release, splinting them, 25 degrees of extension, generally speaking, for a few weeks, scar management, edema management, doing glides to get their nerves and tendons back in shape. PTS, Pernato-Terry syndrome. Key with this is to kind of tease it out. They may just have PTS, not CTS, or they may have both. But it's more on the forearm based. It's more provoked with pronation. That's the kind of the big thing. Repetitive pronation, especially with the elbow flexed, really seems to get it going. How do you test for that? There's a video on that. We'll do this in class. So you resist, you flex your elbow, and the therapist holds their hand back so you kind of resist pronation, like a handshake, and then you extend their elbow out and see if that provokes it. Also could do a Tinels, tapping over that median nerve path in the forearm, palm side forearm. How to treat it, very similar to CTS, rest, modification, workstation, aerobic, median nerve glides. Different kind of splint with this. 90 degrees of flexion, keeping the wrist in neutral. There isn't clear evidence for this. It's harder to get rid of. Not as clean as the CTS, especially with the carpal tunnel release. Similar modalities kind of stuff. And then is it, AIS, PTS? Is AIS damage? Do that AOK sign. See if that IP of the thumb collapses. That's a sign of this AIS damage, anterior osseous nerve syndrome, branch of the median. So kind of make sure it's not that. And always think cervically, always think proximally for all these syndromes with the nerves. Do your Sperlings, do your ruse kind of stuff. Cubital tunnel, ulnar nerve stuff. Elbow flexion test, you're just flexing the elbow. Again, you know your anatomy, it makes perfect sense doing that. You're going to compress it there and see if it provokes it. You can do some Tinels along that median ulnar nerve path on the pinky side. Activity modification, what's provoking it? Usually it's a bent elbow. A lot of times they're on the phone a lot or something. Avoid putting any kind of pressure on that ulnar nerve pathway. Really think, how are they working? What are they doing? Where's their hand as they're driving all day long? As we're talking, if you're mousing, you may be compressing that tunnel of Guyon and that ulnar nerve. Over the long term, it can lead to problems. Splinting, they pad it a lot of times just to protect that tunnel of Guyon. I'm sorry, cubital tunnel. I've been saying tunnel of Guyon. This is cubital tunnel syndrome, right? Cubital tunnel syndrome, which is different from tunnel of Guyon. Cubital tunnel syndrome is up in the elbow. Tunnel of Guyon is down in the wrist. So we're talking cubital tunnel syndrome. Sorry for that mistake. This is all cubital tunnel syndrome. So you're doing the elbow flexion test like we talked about. Avoiding the bent elbow really provokes the cubital tunnel. Padding it really helps. That splint is kind of controversial, but something you can do. Again, ulnar nerve glides. Sometimes they move that nerve to a different area so it's less vulnerable for surgery. Avoid gripping. There's some general guidelines for post-surgery. And if you're trying to figure out, how severe is this nerve damage? Is it like a big-time damage that I need to get the doc involved with? Do you ferments? Pulling with the paper. We'll do this one in class. Do you see if they have a Wartenberger sign? Is it kind of atrophy on the dorsal side of the hand? Again, do your Sperlings and ruse. And here we go. Here's the ulnar tunnel syndrome. It's that little tunnel going into the pinky side of the hand by the wrist. Usually what's causing this, as I was saying earlier, is where they're putting their hand on their computer, on their desk, as they're driving. They're usually compressing it. So you just avoid that and educate them on that. Padding over the tunnel, that sort of thing. There is no specific test for ulnar tunnel of Guyon, ulnar tunnel syndrome. It's just, what you could do is you could try compressing the tunnel of Guyon, see if that provokes it. It may or may not. But where is the pathway of the numbness? Where are they telling you that the problem is? And then we have Decker veins, which is not a nerve issue. It's a tendon issue. So don't think nerve glides for this. Really, the posture is not an issue with this. It's just repetitive motions of the thumb. How do you test for this? The Finkelstein's test, which you all know. What you do need to do carefully is make sure you do it passively, not actively for that. You splint that with the thumb spica, which I think you're familiar with. Avoid those repetitive wrist motions. And then the modalities, again, you're trying to calm it down. Contrast bath. What are contrast baths? You're going from hot to cold. Great way of educating client is fill your sink up with ice and water. Stick your hands in there as long as you can. Take them out. And then fill it up with hot water. And then put your hands in there with the hot water as long as you can. As hot as you can stand for as long as you can. So you're going from cold to heat. And it really works well in terms of calming it down, less pain, less numbness. Makes it more tolerable. Do some isometrics involving those tendons. Gradual strengthening. A lot of cortisone shots. Iontophoresis is very popular in the clinic with this for therapists. Kinesiotaping. We're going to do kinesiotaping for the Decker veins and the carpal tunnel and the PTS in class. And then here's some nerve glides, hidden nerve glides. Those are in there earlier. Those are really common exercise. Just look at them. They're very common sense. Don't get intimidated by them. They're just kind of moving the digits all around and you're gliding those tendons. And then there's some more. There's the tendons. Getting a good stretch through these. Getting into your lumbrical stretches here. Stretching out those intrinsics of the palm of the hand. All good stuff. And it's all in gray, so you need to know it all for the exam. All right, so that is that. Let's go back. to Mr. Peter Parker. So what can we help him with that? If he's got like Decker veins, we could give him a thumb spica splint, iontophoresis, tell him to stop doing so much texting. And then the wrist pain, he probably has carpal tunnel. Give him that splint at night, 10 to 15 degrees extension, some nerve glides, posture, check out his neck and stuff to see what's going on, and we can fix him up.